Record. Okay. So we somehow jumped ahead a little bit. Okay, we are officially recording our webinar now. I'd like to introduce you to our OBRC team. And so again, my name is Sarah Bellotti. I've been with OBRC for I'm just a few days shy of a year and a half. And yeah, yay. And I'm here with my co-host, our director, Becky Mantle. And she's going to be helping me out with this webinar today. I also want to make sure that you are introduced to our Amanda Parsons. She's with us. And then our dear Patrick Andreas, who is somewhat on her way out. She will be leaving us and going to Miami. Neither of them are here today, but we always like to mention them. We also have our Oklahoma Breastfeeding Hotline team. The hotline is managed by us here at OBRC. Some great lactation consultants who are on call 24/7, 365, out there answering calls and now even text messages for our Oklahoma moms and indeed even just moms from around the U.S. So let's get down to brass tacks for today. Our objectives for today are to discuss the cycle of a suboptimal hospital experience, or let's just say a suboptimal breastfeeding experience for a breastfeeding family. In turn, we're going to also describe the cycle of an optimal experience for a breastfeeding family. My goal for those of you who are listening is to, by the end of this, you could list 3 ways that hospitals or clinics can help improve Oklahoma breastfeeding rates. And because we are OBRC, I'd also like it to, if you guys would be able to list at least 1 resource that we are able to provide to help. So let's get down to the who. We have targeted hospitals, clinics, anyone basically who works with in maternal child health with the mother-child dyad, yep. But also called a couplet. And so that's kind of, and it's all of you who this presentation is for. We're all looking out for the same goals, and here at OBRC we work with a lot of evidence-based resources, and we use that to distribute out through our webinars like today, our newsletters, flyers, training, social media. We make sure that there is evidence behind everything that we do. And we greatly appreciate that there are so many other people out there looking into breastfeeding that we can utilize the resources that they provide to give to you and even to the public. And this webinar kind of came about because in my year and a half of being here and reading and learning about all of this, I've noticed some repetition in the areas of concern and the goals therein that we're constantly reading and teaching about. And so I really liked the idea of getting them all together in one webinar. So throughout this webinar, because we do focus on evidence-based, you'll see quite a few screenshots and even hear us mentioning about MPINC scores or MPINC survey. As you can see here, MPINC is the Maternity Practices in Infant Nutrition and Care Survey. We actually just had one that was conducted in the end of 2018. I think they carried on a little bit to 2019. That's officially closed and over. I'm hoping that those of you who work for hospitals that you had someone who was able to respond to that. I'm going to let Becky tell you a little bit more about MPINC just because I'm a little less knowledgeable on that.
Yeah, and many of you I know on this call today have participated in the MPINC surveys before, and I know we'll be eagerly awaiting your benchmark reports. I haven't had any updates on that from the CDC. They did have to extend the deadline in order to try to allow enough time. There were some, I think, logistical challenges they faced this year for some reason, but it will kind of officially count as the 2018 MPINC, and they made some changes in the survey, so I'm fondly calling it MPINC 2.0, and absolutely we'll be eager for those results. And as soon as we hear anything from the CDC, we'll certainly alert y'all to, be on the lookout. I would hope that they can analyze the data and get some results out by the end of the year, but I don't know where that is. So, well, all we can share right now is the last version of this survey, which was done in 2015. So we would have gotten those results, in 2016. So that's what Sarah is showing here today, that our state average was 78. The national average on that survey was 79. So we almost hit the national average. I was quite hoping we would at least equal that. And our overall rank was 28. But you can see below how much our hospital scores improved over the course of this first version of the MPINK survey, from really a low of 55 to a 78 on the last round. So that was pretty exciting to see that much progress.
Yeah, it's really great. It's always nice to, especially when it's something national, to see that, see where Oklahoma ranks and how we're improving, and that's great. And that's strictly all because of those of you who are listening, and also Andy and Becky. So that's just wonderful. So let's get down to it. The cycle of suboptimal experience for breastfeeding families. So as I mentioned, I had seen some repetitions and in the evidence and the things that we talk about often in all of our training and everything. And that kind of led me to finding these 5 things, which then correlate with each other. So we have, first and foremost, on the top, we have our lack of staff training, and then we have our lack of prenatal education, and then suboptimal hospitals support. These 3 things then have some form of an impact on families being able to whether or not they can achieve their breastfeeding goals. And then breastfeeding itself, for those of you who, and I'm sure most of you already know of benefits to breastfeeding, one of those awesome things, which we'll discuss later, is how it can really help with the health of both mom and baby, and and just everyone all around. Well, okay, so let's talk about what we can do. And so we'll take these just one by one, but it's going to go by quickly. So first off is our lack of staff training. So the issue, what does the evidence say about this? The evidence tells us that, and I know this is a duh moment, but well-trained health professionals provide the best support, and in general, and then specifically for us, breastfeeding. Now, again, you're going to see this screenshot here from the 2015 MPINK, and so you can see here of the hospitals that responded, which we had 43, I believe, that responded that year.
That was 80% of our birthing hospitals at that time.
So that was great.
So a very good response rate.
Yeah, and so we have from those 32% gave their new staff breastfeeding education. 39% gave current staff. And our rates go up a little bit as long as staff receive something in the past year, based off of when the survey was taken. And then assessments of the breastfeeding management and support annually, and that's at our greatest percentage at 70. And one thing that I also saw in my research on this, evidence also shows that we don't have to restrict breastfeeding education to those working in maternal child health specifically. And they gave samples here, pharmacists on evaluating medication, thank you, safety, and then social workers on those resources in the community. There's the list can go on, and so anybody could, not anybody, but a lot of people within the health field can help out with this breastfeeding, because we all know, especially for new moms, there's a lot of questions, and you might need to be in one of those areas to be able to really properly answer it. So in handling this issue of lack of staff training, the strategy you can take is to, as it mentioned in the survey, assess health professionals' skills and knowledge. So when you're doing that, what you're looking for is to be able to can they discuss the importance of breastfeeding? Can they educate women prenatally, or are we educating women prenatally? Encouraging that skin-to-skin contact, and for those of you who don't know, it's this great way to help baby and mom bond. It really helps with milk supply, and darn it, who doesn't want to hold a baby? So the other thing we for knowledge and skills to assess is you're okay.
I did that.
Is to help mothers initiate breastfeeding within the first hour. And I try not to say this too terribly often, but what it essentially comes down to is breastfeeding, yes, it is natural, but it is not always going to be easy. And that's where the moms need all of the help and support that they can get. And then lastly, the importance of exclusive breastfeeding, which is something that's suggested by the CDC, the WHO, UNICEF, us, OBRC, the Department of Health, all the benefits that come from breastfeeding, especially if you can get mother and baby to exclusively breastfeed for 6 months, are just so astounding that everyone is suggesting or encouraging that happens. So we've talked about they need, implementing training and specifically what on, and here is kind of the how. You have your options. You can have your staff trained whether online or in person. And of course, our webinar, so I put us at the top. We have options, which I'll talk about later. We also you can reach out to the USBC, the United States Breastfeeding Committee. There's lactation education resources, the American Academy of Pediatrics, and these are going to have staff and physician educational opportunities. And so that and so when I say staff, I'm not even limiting it to, I mean everyone. Like I said before.
So before you go off that side, so the link that Sarah has here for the U.S. Breastfeeding Committee is actually going to go to, they have a great document that outlines competencies that anyone working in maternal child health, whether it's nursing staff, physician staff, lactation consultants, you would hope they would have that, but anyone that's going to be, kind of in a hands-on environment, some basic competencies that everybody should have. So that's sometimes a good document for people to utilize to evaluate what training they are offering their staff.
And so when you say competencies, you're talking skills and knowledge, right?
Yeah.
So like I said, I put us at the top. Let me just quickly let you know what we do here at OBRC. We offer in-person classes for breastfeeding training absolutely free. This comes to us from the Oklahoma State Department of Health through the Maternal Child Health Title 5 block grant. And basically, our goal, this comes out free from the Department of Health because our goal is to get that evidence-based breastfeeding education out there. And we'll probably mention this later, but the evidence-based is just so important because we have so much information in our World Wide Web that anybody can go on and find. And we just like to know that there are places out there that are making sure that the evidence is backing what the moms are reading. So we have our 2 in-person trainings. We have our 1 day, which you can get 7.5 continuing education hours for. We schedule 4 public classes a year for this, and people can register through our website. And we also have a 2-day training, which is the 1-day training plus an extra day where Becky can, with additional, an extra day of additional information and kind of let you get a little bit more into the weeds there, Becky.
Yeah, so the 1 day, the Making Breastfeeding Easier training is one, as she said, we schedule quarterly here on the Health Science Center campus, but this is our on-demand class as well. So hospitals and many of you have had this class at your facility. So this is my traveling road show, and it does help those of you that are working on baby-friendly designation or redesignation. It does help meet some of the baby-friendly requirements for the clinical skills training as well. And then the breastfeeding basics and beyond it it really includes all of the information from the one-day class, and then some additional information, and that's particularly geared for actually all of the health department's home visiting staff. Children First nurses, parents as teachers, and so forth are required to attend this training. And so we schedule this also quarterly, twice in Oklahoma City and twice in Tulsa. But we do open it up to other people to attend as well. So.
Let's see. So we've talked about our in-person classes. This is just a quick little look at our 15-hour online training that we provide. And these are our 15 modules or topics that are found within there. This online training is $60 per person, self-paced, and available through us and utilizing a system called Digital Chalk. It's brand new for us, and well, so far we like it. Now, I've mentioned that $60 per person, but it's only $30 per person if your hospital is a part of the Becoming Baby Friendly in Oklahoma project. So feel free to contact us at any time to just get some more information about that discount if you would like. Speaking of that, I mentioned we have those 3 types of trainings. And I had showed you a map earlier of all the different hospitals by county. And I just want to show you this. As far as what I can see of those who have or are taking our trainings, I can confirm that the areas that are now in black are areas where I know that there are hospitals who are training their staff for breastfeeding. And I know that there's more in Oklahoma City. So in Oklahoma County, 5 of the 9 hospitals are doing it. And in Tulsa County, I have 2 of the 6 birthing hospitals. So doing really good there. And if you know, like if you're at another hospital that is, maybe I missed it and I don't have your county marked, or if you are doing breastfeeding training for your staff, we would love to hear that, because our knowledge is limited to what we do. So if you are training your staff, give us a shout. Let us know. We would love to be able to mark you down and just know who's doing what out there. So essentially, all this can lead us from a change in the cycle of lack of training to a evidence-based trained staff. And our issue number 2 is lack of prenatal education. And the evidence about this says that we tend to overestimate the amount or the information and the quality of the information that pregnant women are receiving. And again, this is on the web, on social media, and even family and friends. People, I'm sure whenever, I do not have children myself, but I'm sure when you're pregnant, everybody tries to tell you all the things. So evidence also says that encouragement and education from healthcare providers can increase the initiation rates of breastfeeding, the exclusivity of breastfeeding, and even the duration. I mentioned earlier about the WHO and UNICEF, and they actually would really like to see babies being breastfed up to 1 year, if not more. 2 years. 2 years, if not more. Sorry, thank you, Becky. That's why Becky's here. So the strategies, I pulled these from the Academy of Breastfeeding Medicine, their protocol number 19. I did not pull everything from there. They had quite a few options, but the ones that stuck out to me here, they suggest that to increase your prenatal education at your facility, that you create a breastfeeding friendly office and community. And that even is just, do you have a lactation room or some kind of space, and do moms feel comfortable going into their facility or their work even?
Are they encouraged to breastfeed while they're in the waiting room?
Right. Yeah, absolutely. Another thing that the ABM suggests is to consider the background and the culture, the ethnicity. As I mentioned earlier, getting misinformation from families, you really got to look into, and that's, I will admit, I don't know the culture, restrictions for breastfeeding, but I know that there can be some that are against it, and or that it's frowned upon. So you really got to take those into consideration. You might be the only person in your mom's corner. Take a detailed breastfeeding history as a part of prenatal history. I don't know how many places already do this. I am curious to find out, but it is something the AVM suggests if you're not already doing so. They also suggest to discuss breastfeeding at each prenatal visit. So we're talking first trimester, second trimester, even into the third, and they give some specifics. And we will be providing these slides to you afterwards. So and don't worry about the little details that are here. I do have some samples of prenatal education that were recently sent to me. We have some great options. Here's a 2-pager from St. Anthony OKC, and we see here on the right, we've got breastfeeding information there. Integris also has a nice little, this is actually, it's larger than this, and I cut it down, but they talk about breast milk is best here. And then on the next page, kind of talking about the skin to skin, the rooming in, the different things that that they utilize for their hospital, that all connected with breastfeeding, because Integris Baptist is a baby friendly hospital, so they include this information in with theirs. And so it really is just kind of that simple, that just provide the mothers with something that tells them the benefits of breastfeeding for both them and for baby, and even addressing some of the issues that they might run into.
So, so before you move on, Sarah, just the protocol where she was pulling some of the recommendations from the Academy of Breastfeeding Medicine. Some of you may not be familiar with that, but the Academy of Breastfeeding Medicine is a physician organization, and they actually get funding from the federal maternal child health to develop all kinds of evidence-based clinical protocols, and they're up to like 30-something protocols. So that's a really great resource as you're maybe implementing, new policies or practice changes, or dealing with hypoglycemia or whatever it is. They'll have a really good evidence-based protocol that will help navigate some of the challenges we face that can derail breastfeeding, perhaps. I'll turn it back to Sarah.
Okay. I really do like that AVM site. I utilize that for our newsletters too. And so sometimes you'll see our little breakdowns of what they suggest in our newsletters as well. So let's move on to the suboptimal hospital support issue. Now, some of you may, and some of you may not, know about the 2018 survey that OBRC put out. Our partners were so gracious enough to help us share this online survey, and we were able to reach 525 Oklahoma mothers and get their responses just regarding their breastfeeding journey in general. Specifically for this presentation, I've only pulled these 2 slides. Just it was great to see an 81% of moms not having trouble, because ideally the evidence shows that it's a small number. It's 525. We have way more moms than that in Oklahoma. But so we loved seeing that, but even more so, which the evidence still backs this, but it was nice to see it from Oklahoma moms. The bulk of them experience breastfeeding issues right after hospital, in the first 2 weeks, or while they're in the hospital. So that's just a difference of 10%. So 47 and 37. And so that's why we essentially wanted to create this webinar, is if we can get the right information to them and the right coaching to them before discharge, then it's these nice, these little changes that you can make to help increase the breastfeeding rates. And I don't know if you've ever seen a mama when she has to stop breastfeeding for any reason, and because she thinks that she has to, but the tears, if we could just save some tears.
Well, one thing that's interesting when you look at this, so a couple of limitations with this survey, we don't have demographics. This was just, distributed through social media. So, and when you see that 81% of the mothers who responded said they breastfeed as planned, or maybe reached their breastfeeding goal, or at least wherever they were at the point in time when they responded to the survey. So probably, somewhat of a self-selected population as well. Yeah, I want to answer this because this is going great for me now. But interestingly enough, when you look at the other pie chart, is really 75% had problems with breastfeeding in the first couple of weeks. So even the mothers who are still breastfeeding as planned had, acknowledged that they had problems very early on. And we have plenty of other data to show that the care that moms receive in the hospital in those first couple of days really impacts what's going to happen with them over the next several weeks, and if they'll, if they'll still be breastfeeding at 6 weeks.
So continuing on with the evidence about the hospital support, like Becky just said, the experiences during the maternity stay really influenced the breastfeeding journey for a breastfeeding family. The barriers that are often found within the hospital setting are fragmented care, which I understand to be one nurse for mom, one nurse for baby.
Sometimes, yeah, that can be challenging if they're giving, mixed messages or, well, I can't help you with that. You're going to have to wait for your baby's nurse to come in, or, the nursery nurse, oh, you have to wait. I can't answer those questions. I'll go get your, mom's nurse. Right. So that can sometimes lead to some challenges.
And another one is that now this was pulled directly from a resource. So they have inappropriate practices and routines. Inappropriate is a strong word, but true. And associated with that, I have this screenshot here from the MPINK survey again, where, as we mentioned, all of the various organizations that are pro breastfeeding are pro exclusive breastfeeding for first 6 months. So the MPINK score asks about supplemental feedings being, if they're rare or not. And you can actually see where we were up to 33% in 2013 and then went down. But that's, that's one of what they would consider an inappropriate practice or routine. And then again, just like with our first issue, like I said, all these are connected, is the insufficient knowledge and clinical competence. So do your staff and physicians know how to talk to a mom about supply and frequency cues, night feedings, medication, again, supplementation, and the P's and Poo's. There's a great little chart that I think the breastfeeding committee people had made, where it's a nice little chart of what you should be seeing. I was like, that is just so great.
So for those of you that may have joined in a little bit late, just as she's showing some of these clips from the MPINK survey, they had a few, for example, with this one, and that's showing the Oklahoma hospital average response from the first year of the MPINK. The top bar would be 2007, and then every odd year. So the bottom bar is through 2015. So you basically got 10 years of evolution, if you will, in what our hospital practices. And these are, once again, this is self-reported. So this is not any outside assessor like our baby-friendly hospitals have gone through. So this is what hospitals themselves are saying. And now when the CDC is summarizing this and they're saying supplemental feedings, they're meaning not medically indicated, or unnecessary supplemental feedings are rare. So it's kind of a double negative there.
Yeah.
But we want to see that, we would like to, if you want to, can you go back for just a second? Yeah, we would certainly like to see that, that we have like 80-90% of our hospitals that say, routine or unnecessary supplemental feedings to breastfeeding infants are rare. So that's what you'd be looking for.
So this is one of my favorite. Maybe. Of course not.
You have to go right somewhere.
No, it just doesn't want to work for me.
Oh, darn it.
Well,
we tested this earlier.
We did. We tested it, but either way, this video is this adorable breast crawl video, and you see the newborn baby crawling and pushing his way up mama's chest to find the nipple to feed for the first time. And it is, to me, it really is. It's just this short little 30 seconds, and
you know what? If I do that. Let's try. Makes a difference.
No.
Go away.
Oh, okay. Well, we don't get to see baby.
Do I need to go back into
No, it's fine. Okay. So anyways, I always say it's kind of like rooting for the tiniest, cutest little athlete. And when they get to the breast, it's like, yay, he found it or she found it. And
Touchdown.
Touchdown. And, but I put that in there because Becky has spoke to me before about how it's just so great to watch. And even when you're staff in there, it's something that everybody can, everybody cheers for the little athletes. And it's just so great. So because of the connection and stuff of these issues, we're again seeing the repetition. So when they talk about strategies to change a suboptimal hospital support setting, again, they're bringing up training your staff. And then again, the breastfeeding policies, which we have kind of briefly discussed, and providing community support information. And that's where there's this additional screenshot from MPink. And this, we got a 62 out of 100. And this is one of the things that, I think it should be the easiest change of anything, because and what they're looking for is staff provide appropriate discharge planning, and it's referrals and other multimodal support. And lucky for you guys, OBRC happens to have multimodal things that you can discuss and share with the mom. Oh yes, and then there's also the survey looks into the discharge packs containing infant formula, and I know in Oklahoma we have quite a number of hospitals that are a part of the Ban the Bag. I believe we had something in the mid-30s of number of hospitals listed on that.
About 30 of our 50 hospitals.
And so I think that's why there's such a high 74% of that. But yeah, I think we could easily change it. I'm curious to see what the next MPink report is going to say on that, on discharge information. But we're going to go over in a little bit more detail in just a second. So that's just like a quick, easy look and easy way of changing from suboptimal to optimal hospital support. And coming to our fourth issue, which, as I said, these are, somewhat directly related. So you have your three issues: your training, your education, and your support. There's only so much that you can do because the moms are with you for only a certain amount of time. So it's more of let's make those three things happen, so that way we can try to reduce the issue that we're going to discuss now, that where families fail to achieve their breastfeeding goals. Sadly, approximately 60% of moms do not reach their breastfeeding goals. The common barriers, if you look at it just generally, are inaccurate information, as I said, on the web, or families and friends. And I'm not saying families and friends are always wrong, but I'm also we're a big promoter of evidence-based, and we just want to make sure that whatever the moms are receiving or hearing is backed by that evidence. So lack of education, then lack of support, and this so hospital, community, and workplace. Going a bit more specifically, common reasons why mothers will quit breastfeeding: difficulties with lactation or even with latch. Infant nutrition and weight could end up being an issue. Illness or needing to take medication is another reason moms sometimes quit, and then the effort associated with pumping.
And so those are all actually, that's from a great article that was published in the journal Pediatrics several years ago, and they were actually surprised when they did a nationwide survey just to try to find out, when mothers stopped breastfeeding, why they stopped. And the surprising detail was that 60% had stopped before they intended to. So that really surprised the researchers. But the common reasons that they kind of summarized there at the bottom, those are exactly all the reasons why mothers call the breastfeeding hotline.
Absolutely. And with that being said, let's talk a little bit about this care and support outside of the hospital. Like I said, you have them for so long, and then we let them go into the world until they have an appointment. And so we need to make sure that they are they are armed. They are armed with the information that they need. And so we have the information that they might need to hear, community support groups and meetups that they can do. We have La Leche League is a good example of that. In-home and outpatient lactation care. I want to mention the WIC Lactation Consultant Resource Guide. They update this guide regularly and provide it online, and so this is a great way for for families to find someone in their to find a person, a hospital, or a support group in their region. And by region, they split Oklahoma into I think 4 or 5 quadrants. Additionally, and I think most importantly, why it was appropriate for me to say arm the families is make sure they know about the laws that protect them. We've had moms just recently in Moore and Tulsa, and when I say recently, in 2019 and even just a couple months, who were either publicly shamed for breastfeeding in public or asked to leave when they shouldn't. This is illegal. Breastfeeding is legal in all 50 states. And as long as you are legally allowed to be there, you are legally allowed to breastfeed. No, you do not have to cover up. And no, you do not have to go into a special room. Now, some moms want to do that. That's fine. But we just need to make sure the moms know this, because there are people out there who are going to confront them. And we need to make sure that they are armed. Informed. We'll start saying informed. And then, of course, the Oklahoma Breastfeeding Hotline. And so here's one of our little advertisements that I post on social media on our OBRC Facebook page. And as you can see, we now have texting. So we are a 24/7, 365 hotline that moms, physicians, anybody can call if they have some breastfeeding questions. And now they can text, and they simply text OK2BF to the number 61222. And then they can start texting with the lactation consultant. We have options for those who like to talk and those who like to text. Another referral of breastfeeding support would be COBA, the Coalition of Oklahoma Breastfeeding Advocates. On their website, you'll see here I'm on the Breastfeeding Help tab. And look at that, on number 2 is the WIC Lactation Consultant Resource Guide. So even just a list of good websites to go to on that prenatal education and on the discharge bags or discharge papers that you give them. It's as easy as that. Just go here for help. And then that will lead us from a change of families failing to hopefully more families achieving their goals and the benefits therein. So now to our final issue, the increase in medical costs. And I know this one seems to be a little bit of an outlier, but bear with me, I promise it's connected. So essentially what I want you to do is look at this. Oklahoma, this is not new news. We are not great in health rankings. We are in that last quadrant. We are 47. We're not 50, but we're not far from it. I would love to see these health rates go up, and so would the Department of Health, and so would you, I'm sure. Now, I do have to give us some kudos, not us, OBRC, us as in you guys who are listening. We are now ranked 39th in infants ever breastfed. We went up from 44 to 39, and that is something that was recently released by the CDC just this month. And Becky, what do they gather that for? What is that report?
So every August, the CDC releases their most current breastfeeding rates. Those are taken from the National Immunization Survey. And what's nice about that, even though there's a 3-year lag time, so the data that came out this month for 2019 is based on babies who were born in 2016, because of course they report ever breastfed or breastfeeding initiation in the hospital or pumping or what have you, all the way through when that baby turns a year of age. So they need a couple of years. If you figure baby's born in December, they want to track them for a year. So there's a 3-year lag time, but it does give you the ability to compare across states and then across demographics and across racial and ethnic groups, where if we try to sometimes break that down at the state level, we may not have quite enough numbers. So we're always eager to see these numbers. And we came up in every category this year and actually increased our ranking in 4 out of the 5 categories that they track, including our exclusive breastfeeding outcomes at 3 and 6 months. So that was very exciting to see.
It's wonderful. Everyone's doing a great job. So continuing on with this, unfortunately, we have a 7.4 infant death rate. The national average is only 5.8. And similarly, we have a 23.9 rate for maternal deaths, where the national average is only 13.3. So we really need to get that health up. And that's why we talk about this along with breastfeeding, because of the benefits of breastfeeding to both mom and baby. So that's why I said, bear with me. This is relevant, I promise. Here's a larger little look at that MPINK survey that we had discussed. And so here's where we just kind of really did well, I would think, for in the last few times. So we've got some good, we got good rates in this last one for our hospital policies, and we've already talked about the feeding practices, and then our discharge protocols, which we just recently mentioned. I really think we can get that up just by simply referring to a few things, on a few extra things, whether it's a website or what have you.
So this is based on the CDC's. While each hospital that completes the MPINK survey you'll get your own individual benchmark report, and you can see how you compare to other hospitals in Oklahoma, other hospitals in your size category, number of deliveries and so forth. But then the CDC does a summary for the state as well, so that, and then that's publicly available. That's posted on the website, and they'll distribute that to policymakers and legislators and so forth in each state. Here's your state's report on the MPINK survey. And so this was actually, since in 2015, it was 10 years of MPINK, they pulled out a few kind of key practices to highlight, trying to maybe put a positive spin on what are still pretty poor numbers, but to show, for example, how many hospitals reported that they had a complete hospital infant feeding / breastfeeding policy. Well, the first year we did the MPINK, that was 7%, only 7% of hospitals said yes to that. And then we, zoomed up to 31% over 10 years. Well, that still means we have about 70% of hospitals in 2015, at least, that did not have a full evidence-based policy. So that's kind of gives you an idea of what they're trying to show there.
So now what I want to mention is bring this back to those specific health benefits. There is a Breastfeeding Saves Lives calculator created by Ann Stu.
Oh gosh.
Goodness.
Oh, he was involved in that.
Either way, it's genius.
Allison Stubbe.
Yes, Stubbe.
And the two key physicians working on this have actually been speakers at our summit.
Oh, that's wonderful. Oh, wonderful.
I'm blanking on the other name right now. So,
so on this calculator, you can go to that link and click it, and it gives you some great numbers. But essentially, and Becky made this for me, if we were able to achieve 80% of exclusive breastfeeding at 6 months, our rates, which for this one at the time we had, if you look down to here, for 6 months exclusive, we had 21.3%. But if we went up to 80, then just in doing that, you make all these changes across the board, and it leads to all these great changes. But how specifically for this webinar, where I say we can reduce medical costs, this is where that calculator, when you go onto it, it breaks down so many more areas where money is saved and lives are saved. But this is, you'll notice that's 6 places after that first comma. We're saving lots of money just by getting more mothers to exclusively breastfeed. So it saves in medical costs, non-medical costs, death costs. Even more importantly, how I had said we were above the national average on maternal and child deaths. if we can increase breastfeeding rates, we can save some moms. We can save almost 30 moms and almost 10 children. That is just wonderful to me. Let me show you this next slide. This is what I mean by that specifically. So evidence shows that breastfeeding has an expected impact on these, on the left, these 5 maternal diseases, and there on the right, these 9 pediatric diseases. So when they're saying save lives, they really do mean that, or saving money and saving lives. They really mean it, because we can reduce ovarian cancers, breast cancers, hypertension, and I mean hypertension, heart troubles are #1 for women.
And these are based on several publications by Melissa Bartik. That's who else was involved in the conflict, who has been a speaker here. And her massive team of researchers calculating how much it costs to treat some of these conditions that possibly could have been prevented. And if we achieve those 80% rates, and that's where the cost savings comes in. So one just point of clarification too, while we definitely have high maternal mortality rates, that's deaths related to either childbirth through postpartum and anything kind of pregnancy related in that first year. But here it's talking about it's certainly the health impact to the mother throughout her entire life cycle.
Right. Yes, thank you. So we've gone all through. We discussed that, and so how we can simply make that change in the cycle from an increase to a decrease. We're not saying that it's going 100%, but it helps. So then this all leads us to a new cycle of an optimal breastfeeding experience, which is our same thing, but with everything flipped to the positive. We get evidence-based staff, effective prenatal education, that hospital support becomes optimal, lead to more families going on to achieving their goals, and then in turn essentially decreasing the medical costs. I took this a little bit further down and just simplified it. Essentially, if we can train, educate, care, and then they can achieve, then they can thrive. Oh yeah, I hadn't told Becky that. Yeah, she likes it.
Stuck that one in.
Yeah, I did. So here's my references, and I want to open it up to any kind of questions here for our last 10 minutes of the hour. Yeah, I was hoping you would like that. Again, we just want to thank everyone for coming out, for logging on, and we really appreciate your time. This is only my second webinar to give, and I did a lot better this time around than I did the first. And we appreciate even just seeing the interest. We want to know that people are interested, and we're also curious, what do you want to have a webinar on? What areas do you want to learn more about? We always want to hear that, and try to find a way to give you that information that you need. And of course, our email, if you do want some flyers to help with your prenatal or with your discharge and just any other information, we would be happy to provide you with either a contact person or even with some actual flyers. So you can just shoot us an email at obrc@ouhsc.edu, and this of course is on our website. And of course, and our phone number is 405-271-6162. And you should get me most of the time whenever you call that number. So again, just thank you so much for all of this. Yes, Karen, we do have an updated flyer with the texting information. Unfortunately, we do not yet have it in Spanish, but I did just order a few preliminary flyers for that. And so anybody who wants an updated texting flyer, go ahead and let me know that and how many you think you would like, and I can get you some English ones out. And then once we get the Spanish version made, just let us know. And again, I want to make sure that that you know about our how to contact us, which is for our Oklahoma Breastfeeding Resource Center. So obrc at ouhsc.edu.
So we're getting several questions in the chat box about hotline flyers with the text info. So we're actually, Petra's been working with the WEC department to kind of design some, using their marketing graphics people, so we'll have some pretty jazzy looking ones. In the meantime, Sarah's developed a lovely one that can either be printed out as a full page flyer. We could actually send the PDF out, and as we, have the Spanish translation ready and kind of the whole package, if you will, that will certainly go out on the our hospital listserv to make sure everybody, and get posted on our website, and the health department will post it. We'll try to distribute it through all our channels. In the meantime, she's also developed kind of the little cards that are a little smaller.
Yes.
Cardstock insert
They're
that she's getting printed.
size.
So if you wanted, something a little smaller that you want to put in, that maybe stands out, not another piece of paper, just email her at the OBRC email, and we can get some of those in the mail too. Sure.
And I put our email there in the chat box just in case, and feel free to shoot us an email and let us know. Of course, if you want an eight like a regular size paper, it was 8.5, 8x11, or if you would like a small insert, which is postcard size, and then how many you would want. And then if you just want the electronic version, then just let me know that, and I can send it to you as a PDF or as an image. Really and truly, we'll find a way to get you what you need.
And then also can email anyone who if you have particular staff training needs. Sarah's gone through what trainings we have already developed, approved for nursing contact hours and so forth. But we are pretty flexible as well. So if you have maybe some more specific needs that you want, some updates for your staff, or particular issues, you want addressed through training, we certainly can modify. And always, that's a big piece of what I do, is just working with the hospitals to, help identify, what are your needs, what do you want to work on, and how can we help you with that? So somebody say, what's the minimum attendance number for an on-site class? It's ideal if there's 6 to 8, 10 of your staff. Though sometimes if you're in a community and a small enough hospital that you feel that's a little harder to, maybe you can scramble together. You can pull 4 nurses off the schedule or something. Let us know, because we can always publicize and try to invite if there's health department staff or other healthcare staff in the community. And those are sometimes fun too, because it helps people network and get to meet. Maybe there's breastfeeding peer counselors in the area that would want to come, or, some health department or WIC nurses or dietitians. So we can sometimes kind of do a combo. But yeah, generally 6 to 10 or more makes a good class. So.
All right. Okay. Well, we'll hang about here for a little bit longer, just in case there's more questions, which you can unmute yourself and talk, or you can write in the chat box. I've got that pulled up. But I'll go ahead and officially end here, but I'll stick around until 1 o'clock to answer. I and Becky will stick around to answer any questions. So thank you again so much for coming. We really, really appreciate it. So for how much time in advance do we need? So ideally, we do have reach out to us with maybe some dates in mind, and let us work around our schedule. Becky is on the road quite often, so we have to.
Usually 2 to 3 months. But you can just kind of contact us, and if there's a certain time of year you're aiming for, we can usually find a date that will work for everybody. So.
2 months. 2 to 3 months would be ideal. Thank you. I still think we need background music.
We need baby talk.
Oh, we need baby coos. Yes. Yes. Actually, I don't know. Real baby might be a bit distracting.
Yeah.
Oh, so great. Yes, baby fever is definitely, especially with me. Oh, I have it so bad. No husband. I just got the fever. You might. You might
Oh my
make too
gosh.
many people let down. It's so true. Oh, it's so funny. Don't know who you 8,500, but you make me laugh. Oh, and again, if you haven't left yet, you know, we have our registration, but if you work or something and you want to let us know real quickly just what organization or clinic you're from, we want to make sure we can reach out to you. Teach on the topic of breastfeeding among the different cultures.
I can't say I've done a specific talk. We usually try, I've probably focused more on sometimes the differences or communicating, you know, amongst the racial and ethnic groups. A lot of that's going to get down to just how we communicate with people. I'm doing a talk tomorrow at the State Weight Nutrition Conference on communicating about breastfeeding, but we certainly could, once again, kind of tailor something to address that, especially if you're, what hospital are you at, Angie, or community?
I feel like I should.
She's still on, so. Yeah, and if there's, you know, specific, you know, cultures in your area. Oh, yes, insist on breastfeeding and bottle feeding. Oh, I hear you there, so.
Okay.
Yep.
Okay, well,
that's common.
You know, and it's actually something, like I mentioned, I was talking about the cultures and stuff earlier that the ABM suggests to look into, and that really is a big interest of mine, and I would like to do some more research on it. Maybe we can kind of bulk it up.
We can definitely work on something like that. So yeah, just contact us, and that gets into, like, you know, when I do a training on site, you know, the 1-day MBE Making Breastfeeding Easier class, I can, you know, sometimes just kind of highlight particular areas that might be of, you know, more interest or more need, you know, for a particular facility, or stress, you know, different sections a little bit more. So there's always some ability to modify that somewhat. Of course, I can't make huge changes since it's approved for contact hours. So, but we can always tailor it a bit. All right. Any other questions? So we are about to our hour or so.
All right. Well, thank you again so much. Angie, we're going to keep in touch with you there at Integris Bass, and let you know when we've kind of been able to pick up on that a little bit. And in the meantime, anything that we find just in resources in general, we're not going to make you wait till we read through it and summarize it. We'll send you what we find, and then we all work together.
I see her last question. How cultures that insist on breastfeeding and bottle feeding, and how that goes into offering supplements. You know, the question is who's offering it. So, you know, if it's maternal and staff has tried to educate the mother about, you know, why we discourage supplementation, how that makes breastfeeding harder, it can impact milk supply, and make, you know, it harder for the baby to, you know, feed frequently and so forth. But it's all in who is offering it. And then if it's the mom requesting, you know, what have we done to try to educate her about that? So, all right.
Well, thank you, everyone.
Any other questions? Yes, if we didn't have time, so feel free absolutely to email us about that. So,
okay, and we do, Karen, have some
postpartum depression.
Yeah, we do have some.
We don't need to know. Just email us, you know, what your specific question is that you want to try to address.
And then what we have on our site too. All right. Well, we got to stop the recording here, but thank you again so much, everyone. We really appreciate you. Yeah, more. Yeah.